Happy New Year. Katy Lee's here, Principal 340B Compliance Advisor with Virtue 340B. I hope everyone had a great holiday season. I hope you were able to, escape work, escape the chaos of 340B and enjoy some just quiet and relaxing time for the holidays. However you celebrate, I just hope that, it was a nice quiet time for at least a day. You're able to take it for yourself. We didn't get that much quiet time over the holidays in the 340B program. There was quite a bit going on. I will say we somewhat got a gift. I'm considering it a gift for now. But there was still a lot to keep track of when I thought it would just be a quiet week between Christmas and New Year's. And that's what I want to talk about today, just how we're navigating all of this, how at Virtue 340B, we've been hearing from many of our clients. It's just like, what are we supposed to do with this information? What are our obligations right now? How can we still ensure that we're, that we're participating in the 340B program as we need to be, but that we're maintaining compliance at the same time? So I put together a slide deck, which those of you that are joining on our YouTube video series today of Katy's 340B Compass, you will see I'm not on video today. I decided just to go right with our slides so that, it helps me. This is very complicated. There's a lot of details to keep straight. So honestly, the slides might be more for me to keep it all together and keep me on track as I go through this. But hopefully you'll find them helpful too. We do have a new way that you can catch Katy's 340B Compass or listen to Katy's 340B Compass. The videos are now also available as podcasts on Spotify, iHeartRadio, and Apple Podcast. So, even if you're not watching on the video today, these slides will be available. They'll be available on our website. We will be sharing them on LinkedIn. And if you have any trouble finding them and you want them, just reach out and ask. Because we definitely just want to help everyone navigate this really complicated time. So let's get into it. Let's just, walk through what all of this means and how, what we should be thinking about, what we should be doing. I guess I should give a disclaimer in that, all of this is going to be somewhat high level. I always say if you've seen one covered entity, you've seen one covered entity. So I can't sit here and give you all advice on, what to do in a very detailed manner. That's something that is based on, what type of program you have, just a lot of different elements. So, I'm going to keep this somewhat high level. And I just hope that it can be a helpful resource to you while you're having your internal discussions. You're talking with your pharmacies, your operations team, finance, legal counsel. This should really be a time where we're all talking about what's going on and how best to proceed for each individual covered entity. So I hope that you will find this information helpful. So let's just start with what we were expecting versus, how things are changing. So what we were expecting is that beginning in January 2026, new federal drug pricing policies will go into effect, and they have, with how certain Medicare prescriptions are reimbursed. These changes are stemming from the Inflation Reduction Act, which we will talk about how this intersects directly with the 340B drug pricing program. And on that note, in August of 2025, HRSA introduced a 340B rebate pilot policy due to that intersection with the 340B drug pricing program to address duplicate discount prevention concerns related to the MFP rebates. The rebate policy, as I probably don't need to tell many of the people listening, represented a significant departure from, how we have been participating in the 340B program for decades, where the 340B discount was, upfront at the point of sale. So the transition to a rebate model where you would retrospectively get that financial benefit as a rebate just introduced a whole new world of financial, operational, and administrative risks, and just layers of complexity for covered entities. We were, as covered entities, anticipating material negative impacts from the implementation of the 340B rebate pilot, including cash flow disruption, increased compliance burden, and just a lot of uncertainty in how we were going to be purchasing our drugs, how we would be reimbursed for the drugs. So this has been a topic for many, many months, and something that many covered entities have been trying to figure out how to deal with, which, yay, we get a little bit of reprieve from that, but certainly doesn't mean we're absolutely off the hook. So as a result of subsequent litigation that was initiated by the American Hospital Association along with a few other stakeholders, the implementation of the rebate policy has been delayed. This is temporarily, preserving that upfront 340B discount model that we're all used to. But despite the delay, covered entities do still have a responsibility to prevent duplicate discounts where there's an overlap between the 340B discounts and maximum fair price rebates. And we're going to get more into, what that means for those of you that might be like, yeah, this is a lot of abbreviations and words and policy talk that I don't know about. But if that's the case, we're going to get more detailed. Don't worry. So a little bit more about the current legal and policy status. So as I had mentioned, the American Hospital Association and other stakeholders filed suit against HRSA, arguing that their rebate policy exceeded the agency's authority and also just really failed to account for, how much covered entities rely on upfront 340B discounts. So on December 29th, the District Court of Maine did agree with AHA and issued a preliminary injunction blocking HRSA's rebate pilot from being implemented. And the reason for this, they were not there to argue the merits of the 340B rebate program, but more so just that HRSA didn't follow the appropriate process when they were implementing this. The court felt that they violated the Administrative Procedural Act. So HRSA obviously was not happy with that, and here we are. That ruling came on December 29th for a policy that was supposed to start on January 1st. So, clearly that was not part of their plans. So they returned to the court, I believe the next day, and, requested a lift or a stay of that injunction. But the court maintained their original ruling and they denied their request, leaving the rebate pilot fully paused at the trial court level. So as the next step, HRSA appealed this case to the U.S. Court of Appeals in the First Circuit. They were seeking them to overturn the ruling that occurred in the Maine District Court, and they just really wanted to be able to proceed with the rebate model as planned on January 1st. So that wasn't really the timeline of all this, wasn't very feasible. The First Circuit Court, did not approve an immediate overturn of that ruling. They did order an expedited briefing. They said that, the court intends to rule as soon as practical after they're able to, after the briefing concludes. But there was no timeline specified when a decision would be issued. So here we are into January, and we're still waiting to hear where we're going to go from here. The current status is that the 340B discounts are still in play. By the end of the day, on December 31st, HRSA had posted on their webpage that the rebate policy the rebate pilot policy was on hold, and that manufacturers were to continue issuing upfront 340B discounts until further court action. So here's our key issues at hand that we're going to talk about today. The Medicare drug pricing reform is moving forward. So IRA was not paused. The maximum fair price is in play as of January 1st. This alone just results in greater complexity, in the pharmacy space. MFP lowers the reimbursement and adds new administrative and financial complexity. That's even outside of the 340B program, but certainly even more so, where there is intersection with the 340B program. As I mentioned, HRSA's rebate model was intended to manage the duplication risk that comes with that intersection of MFP and the 340B program, which we will talk more about. The court action paused the rebate model, which, we have to celebrate for a second. That's where I said we kind of got a gift. But it did create a lot of uncertainty. It definitely is not a time to just say, we won, it's over, we don't have to do anything. That is absolutely not true. CEs do still have the responsibility to prevent duplicate discounts under the rules that went into place for January 1st. So in the Inflation Reduction Act, it's stated that there cannot be duplication. Manufacturers are not required to pay an MFP rebate and provide a 340B discount. So, CEs have a responsibility to manage this. And we have an opportunity. We need to show, the other stakeholders that we don't need a rebate program to manage the duplicate discount issue at hand. I think that's a key point that we all need to be thinking about. This is our opportunity to show that this can work without a rebate model. So from policy to practice, what do we do now? What matters is that we understand how these changes are working, what's at play here, and what do we have to do in response to them. So first, let's just talk about what is maximum fair price. So the Inflation Reduction Act allows the government to negotiate prices for select high-cost Medicare drugs. This is intended to be for single-source drugs with no generic and no biosimilar competition. These negotiated prices are called maximum fair prices, so that's where we get MFP. And they're right now limited to Medicare Part D drugs. In 2027, that Medicare D drug list will expand, and then in 2028, we start to get into Medicare Part B drugs as well. So this is intended to roll out over many years and just expand year after year. The selected drugs billed to Medicare Part D will be adjudicated at this maximum fair price. And on average, it's about 60% lower than those drugs were reimbursed at, before January 1st. Manufacturers can opt to sell these drugs at the maximum fair price, or they're required to issue a maximum fair price rebate to the pharmacies to reconcile the difference between the acquisition cost and the reimbursement. Because as I mentioned, these drugs are now being reimbursed at 60% lower, but the pharmacies still have to buy the drugs at, whatever price point they're buying it at. So wholesale acquisition cost, if you're buying it at wholesale acquisition cost, you now might be being reimbursed 60% lower on it maybe than your drug cost. So that's where the manufacturers have to issue these rebates to make the pharmacies whole. And if you are able, if you're a covered entity and you purchase your drugs at the 340B cost, then it's in most cases that 340B cost is lower than the MFP price, but not always. So this is something I talked about in my last video, and we certainly at Virtue 340B have some resources on this, because this is also something to be mindful about, is there are times where MFP is lower than 340B. So it's really probably best to just carve those out of your 340B program. I'm not going to get into that too much, but I just thought it worth mentioning there. And then the other nuance that, I want to mention, and I have this in a later slide as well, is that, like I said, manufacturers can opt to sell drugs at the MFP price. So before we got into January, so, the month of December, and even before, there was a lot of rumors about some of the manufacturers in scope of this lowering the WAC cost of their drugs. And just for those of you who don't know, I don't think I gave wholesale acquisition cost. We just refer to it as WAC in the 340B space. So some of the manufacturers were rumored that they were going to lower the WAC cost to equal MFP, so then they wouldn't have that obligation to issue an MFP rebate to pharmacies. So there was a number of drugs that I had heard rumored that this was going to happen for, Imbruvica, Eliquis, Farxiga, and I'm totally blanking on the other. There was a fourth one that's escaping me right now. But as of the day I'm recording this video, which is January 7th, I have checked these, and Imbruvica is the only one that I've actually validated that the WAC cost has been lowered to equal MFP. All the other drugs, there are other drugs, those drugs that I named, the cost of those drugs have been lowered, and I think significantly lowered, but they do not equal MFP. So while the regular purchase price is lower, and this is across the board, manufacturers will still have to issue MFP rebates because the drug cost is still higher than that maximum fair price. So here are all of the drugs in scope of the maximum fair price reimbursement in 2026. Eliquis, Enbrel, Entresto, Farxiga, Januvia, and Jardiance. Jardiance is the other one that had been rumored that it was going to lower the WAC cost to equal MFP, but that did not happen. Novolog and Fiasp, Stelara, and Xarelto. So here we'll just talk about the intersection of MFP and 340B. Here's where it starts to get even more complicated. So as I mentioned earlier, the Inflation Reduction Act stated that manufacturers I'll say it prohibits manufacturers, but they're not required to provide both an MFP price adjustment or MFP rebate and a 340B discount on the same drug. So this is the new version of duplicate discounts that we need to be mindful of. It's very similar to duplicate discount restrictions that apply for Medicaid prescriptions. And to address this overlap, because the Inflation Reduction Act was announced and published, formalized years ago with that stipulation, but there was never any, real operational consideration put to or no guidance or rules put in place to prevent those duplicate discounts. So that's what pushed HRSA in, as I said, August 1st of 2025 to establish the 340B rebate pilot. That was their solution for preventing this overlap. That would allow the manufacturers in scope of the maximum fair price reimbursement to transition those drugs in scope from upfront 340B discounts to retrospective 340B rebates. And as probably most people listening know, that rebate pilot was scheduled to begin January 1st, 2026, but instead it is on pause until further court action. So just a little bit more about HRSA's 340B rebate pilot, because as I mentioned earlier, it's on pause. It has not gone away. So we should still, be making sure that we understand what all this means and be ready to go. We had a conversation the other day. If the courts, all of a sudden rule that this temporary injunction is lifted, what does that mean? What type of notice will we get for this? I'm not sure. I'm sure legal professionals might know that there's some requirement. But I'm not sure what that timeline will look like. I can't imagine they can say tomorrow. But what if they say next week or next month? We still just really need to be ready for potentially moving forward with this 340B rebate pilot. So the drugs in scope of the 340B pilot will no longer be available at 340B pricing in any setting for any payer. So, as we talked about, that maximum fair price, that's all going to be in our outpatient pharmacy setting. And again, that's only for prescriptions billed to Medicare Part D. The rebate pilot was not limited in that way. It was these drugs in scope that list that I just went through, they, in any setting, any covered entity will now no longer be able to purchase that at 340B upfront. Instead, covered entities will have to buy those drugs at wholesale acquisition cost and then submit prescription and medical claims data to a third party, which we all know is Beacon, to request the 340B rebate. So as we talked about, this represents a fundamental shift in how the 340B program has operated for 3 decades. Increasing the administrative and financial burden to covered entities. And in the 340B rebate pilot, manufacturers play a really large role in determining rebate eligibility, which leaves me concerned, that there's going to be additional review steps and more denials than we would necessarily expect. It really, there is certainly framework that HRSA put into place. I will say that the policies that were published on October 31st seemed that they took that to a new level or another level. And to see it, in real practice, it's concerning because covered entities really have very little power or control in that process. And where things stand today, so the rebate implementation is paused. We talked about this court action that has paused it. The upfront 340B pricing remains in effect. And as I said, let's take a moment to acknowledge that this is great. Like, this is good news. It was a gift that we received, but it doesn't mean that we're just off the hook and that, we just carry on business as usual. We need to be considering this duplicate discount risk and our obligation to maintain this compliance. And as I said, our opportunity to show that we can do this. We must prevent the maximum fair price duplication. It's not written in the statute that covered entities alone are absolutely responsible. I don't want to get any hate mail for giving that message, but if we want to prove that this can work without a 340B rebate model, it kind of is our obligation to make sure that we can make this work. We are responsible for ensuring that MFP rebates are not received on 340B eligible transactions. On the other side, there's some concern of what happens with non-340B transactions. Like, for a covered entity that has a hospital-owned pharmacy, maybe not every prescription qualifies for 340B. So just another thing, just a little bit of a sidebar, that covered entities should be aware in monitoring the MFP rebates to make sure they're being received as expected for non-340B transactions. Because what if that is a solution that the manufacturers decide is, the best way to go, is just not to pay MFP rebates on if a covered entity if a hospital is participating in the 340B program. Maybe they just won't pay them any MFP rebates. But I imagine that that's usually not accurate, and that's probably going to be denying covered entities MFP rebates are entitled to. And maybe that won't happen. I certainly don't want to be an alarmist or say something that's ridiculous. So, I'm just saying, monitor. I can see, that's not an unreasonable approach from manufacturers, because we know that there's a lot of misunderstanding on, 340B within a hospital-owned pharmacy, and just assumptions made based on the Medicaid exclusion file. I've talked about that in past videos. So just something to be mindful of. And then again, continued readiness is essential. We need to be continuing to prepare for the potential rebate model, because it could be reinstated at any time, just based on future court decisions. And there's not even just the limited stay for the pilot program. We have another rebate, a more broad rebate court case that's pending a decision as well. So just, it's not a time to just completely relax and forget about all of this. We need to remain ready. So we'll get into now just a little bit more detailed on preventing those MFP duplicate discounts. So basically what we're talking about here are prescriptions adjudicated on or after January 1st, 2026. Covered entities must comply with the IRA requirements by preventing duplicate discounts for prescriptions that qualify for the 340B program and for the maximum fair price rebates. This applies to contract pharmacy and in-house dispensing environments. The prescriptions, you need to be mindful of what prescriptions are in scope of that MFP rebate, which I'll get into a little bit more detail on that on the next slide. And this will require operational controls where system automation might be limited, because again, this is all just at the last minute. This is not how everyone has been planning. It's not how all of our vendors have been planning to put this process into place for the last, how many months. So at least right now, in January, you might need to manually manage this. And then just, the little clarification, which right now seems semi-insignificant, but, this could continue to increase or evolve. But as of January 1st, 2026, one of the drugs in scope of this does have a wholesale acquisition cost equal to MFP. So in that scenario, those drugs will not generate MFP rebates, and so they're not at risk for the MFP duplicate discounts. And currently, the only drug where WAC does equal MFP is Imbruvica. Again, at least that I'm aware of. So operational options for covered entities. I know you listened to me talk for a really long time to get to probably this one slide that would be helpful. But so prescriptions in scope of MFP rebates, again, are prescriptions that have a date of service on or after January 1st of 2026. They're adjudicated to a Medicare Part D payer. And then in this slide, if you see it on, I have it on the video here, or again, they'll be available after, but I have a link to the drugs that CMS has selected for this. So that report, the link will take you to an Excel file that has the drugs by NDC, which if you're anything like me, I'm a data person, I need those types of details. That's how I truly understand this and can understand, or assess the magnitude of it, is I need that level of data. So the link that I've provided in this slide will take you to the NDC level data. And the way I see it, I mean, there might be, maybe someone else has more to add here. I'd love to hear it if anyone has any opinions or feel that I missed something, but I feel like covered entities have two options here. So option one is that you continue your 340B program as usual and just implement a process to decline the MFP rebates on those 340B prescriptions. So in this case, entities must ensure that the MFP rebates are not received on prescriptions that accumulate for 340B. I think at least today, this is probably going to require a manual process by the covered entity or at the pharmacy level. There are vendors out there that will help you with this. So certainly there's options, but again, are you contracted with those vendors today? It seems most people, it's unlikely. So it's probably going to require some manual work right now. You're going to need access to the pharmacy's MTF, or someone's going to need access to the MTF, which is the Medicare Transaction Facilitator that's managing those MFP rebates. Another option, I believe, should be having access to Beacon's MFP portal, which again, there's considerations there too. The terms and conditions are not great. Certainly, again, please discuss this all internally. Talk to your legal counsel, your operations, finance teams to figure out if this would work for you. But currently, there is no automated mechanism to flag 340B status to prevent the MFP rebates. So yeah, maybe in a perfect world, we would be able to apply claim level identifiers, that submission clarification code 20. If we put that on there and all the Medicare D payers, they know it's a 340B transaction or not, that would be great. I know not all pharmacies, that can be very burdensome, so it's not always an option. And I'll also say, if you're in a state that doesn't have discriminatory reimbursement protections, then sending that modifier to some of the Medicare D payers could reduce your reimbursement in that regard. I know that there are some Medicare D payers out there. I'm not going to throw out a name right now. I'm going to restrain myself. That is, for about a decade, has been trying to, push themselves in and get what they think they're entitled to for covered entities 340B discounts. So right now, there is not any mechanism for us to, identify these claims as 340B to prevent the maximum fair price rebates. So option two is to exclude 340B accumulation for MFP rebate eligible prescriptions. So, this would mean that you would exclude these prescriptions, whether it be in your in-house pharmacy or your contract pharmacy arrangements. You would take action so that they do not accumulate to 340B, so that those MFP transactions can just flow normally. I will say this probably also is going to require some manual intervention, at least right now, because most vendors that I'm aware of cannot exclude prescriptions based on payer and drug. They can do it based on drug and they can do it based on payer, but you want it based on payer and drug, because you don't want to exclude, every Eliquis prescription. You want to exclude Eliquis when it's billed to a Medicare Part D plan. And there probably are some vendors out there that can do this today. And I have to assume that most vendors are working to develop this. Because this, for however long, if we stay in this pause state for any length of time, this really is something that covered entities need as an option. So hopefully this will be something in the future. I know that, one way to manage this temporarily is to, just be on top of your claims in every, however often, let's say every week. Run a report of all of your prescriptions and just manually identify the prescriptions that are in scope by drug and by payer, and just remove those from your program, reverse them out. And obviously you need to be ahead of the replenishment. So if you're going to do that, set up a cadence so that you are making those adjustments before the drugs are being replenished. Because obviously you don't want to get yourself in trouble for reversing prescriptions that already replenished, because then you're not saving yourself anything. So those are what I feel are the two options. Either make sure that you continue your 340B accumulation, but that you're not accepting that MFP rebate, or that you're, reversing it, declining it, however that works. And this is also new. I wish I could give more specific details on how that would even work, but, I'm not sure it would even be the same exact information for every single covered entity or pharmacy. Or option 2 is just ensure that any prescription in scope of that MFP rebate is excluded from your 340B program. So here's my last slide, hopefully this has all been helpful. These are my key takeaways for all of you, and just to do a quick overview of it. So as we talked about, the Inflation Reduction Act's maximum fair price introduces a whole new layer of complexity, especially where it intersects with the 340B program. But honestly, even outside of it, as I mentioned, it's certainly a significant change for pharmacies. HRSA's proposed 340B rebate policy also represents a significant shift away from, how we've just functioned for decades, moving away from that traditional upfront discount model, materially changing, financial, operational, and compliance dynamics for covered entities. And while this has been paused, the implementation of the 340B rebate policy, has been paused, but there's still that underlying risk of duplicate discounts between 340B and MFP rebates. So covered entities must take proactive steps to ensure that MFP rebates are not received on 340B eligible prescriptions. And then, as I mentioned, if a covered entity has their own pharmacy, they also want to make sure that they're receiving their MFP rebates on their non-340B prescriptions, just in case, any of the manufacturers kind of take that approach and just assume that every transaction will be 340B eligible. And I expect that current vendor limitations mean that many covered entities will need to put some manual controls in place, at least temporarily, to make sure that you're able to monitor all of this, document what you're doing. And as I said, either, manually block these prescriptions from accumulating, or make sure that you're not receiving that MFP rebate. And, this pause is just, as I said, it's a critical opportunity for us first to demonstrate that we don't need a 340B rebate model to effectively prevent these duplicate discounts. But it's also gives us more time to make sure that we're prepared and we're able to refine our process if the rebate pilot, does go forward. And then, as I just said, ongoing readiness is essential. So we don't know when this rebate policy might be reinstated. So we need to be ready. This is a pause. This is temporary. This is not, I don't think that the rebate policy or the rebate pilot is completely going away. So I hope that you found this helpful. I did add a couple of resources here at the end, a link to HRSA's rebate policy page, and then also CMS's page that has more details on the Inflation Reduction Act and maximum fair price. So as usual, we are available at Virtue 340B as well to be a resource to you. We certainly want to help tackle all of these just complicated developments as we, continue to just live in this very chaotic world of 340B. But, we're also here just to help you with general compliance. That is our core mission, is to just be an independent auditor in this space and just help stakeholders, manage their programs and be great stewards of the program. So thanks for listening, and I hope to talk to you again soon. Bye. Do you have a 340B compliance question? Send us a message at virtue340b.com. Thanks for tuning in, and we will see you on the next episode for more expert 340B advice. Talk to you soon.